The glomus tumors are relatively rare tumors, but they can be asked in theory and OSCEs and also as spotters. So in the next few minutes, we will be dealing with the etiology of glomus tumors, epidemiology, pathophysiology, classification, clinical features and also management, which includes investigation and treatment. This glomus tumor is a neoplastic condition involving the temporal bone. It is histologically benign but having a malignant course because of its bone eroding property. It erodes the skull base and also it goes intracranially because of the bone destruction by the growing tumor mass. The etiology. This glomus tumors originate from the paraganglia, chief cells of paraganglia or glomus bodies. Okay, and the paraganglia are very small clusters of tissue, basically less than 1.5 millimeter clusters of tissue composed of epithelioid cells within a network of capillaries and precapillary network of vessels. Okay, so these paraganglia or the glomus bodies are located within the adventitia of the jugular bulb. Wall of jugular bulb, and they are also associated with the auricular branch of vagus nerve and also the tympanic branch of glossopharyngeal nerve. Okay, so the 9 and 10. So, and these paraganglia are supposed to be believed to be originating from the neural crest cell, and they also secrete catecholamine, or they are called the chemoreceptors. So that is why the glomus tumors are otherwise called chemodectoma or non-chromaffin paragangiomas. Okay. Paraganglioma. So the glomus tumors, otherwise called chemodectoma or non-chromaffin paraganglioma, originating from the paraganglia, which are situated in the adventitia of the jugular bulb and also the auricular branch of vagus nerve and the Jacobson's nerve. And this paraganglia are they are neural crest origin and they secrete catecholamine. And the number of this paraganglia, they increase till the 4th decade of life, and after that they decline. So that is why these glomus bodies are mostly seen between the age of 40 to 60. Okay, between 40 to 60 years of age. And it has got an autosomal dominant inheritance with an incomplete penetrance. It is more common in female with a male to female ratio of 3 to 6:1. So it is more common in female, and the studies show that even in female this is more commonly seen on the left side than on the right side. So that is the epidemiology. Okay, between the age of 40 to 60, more common in females with a left-sided predominance than on right. And in the pathophysiology, I already told you, it is arising from the paraganglia. And this paraganglia, they are arranged in clusters of epithelioid cell or polygonal epithelioid cell with a very clear and abundant cytoplasm. And they are arranged in a pattern of this alveolar pattern or like a cell ball. Okay. So it is a typical alveolar pattern with cell balance. What is that cell balance? Cell balance means cellular balls in German. Okay, so cell balance means cellular balls in German. So it is the paraganglia or epithelioid cells are arranged in like lobular arrangement with a ball-like arrangement, like in clusters. So they are called cell balance. And 4% of these tumors will produce catecholamine like norepinephrine and dopamine. So it will mimic the symptoms of pheochromocytoma, and also pheochromocytoma, parathyroid adenoma and thyroid carcinoma are associated tumors associated with glomus tumor. So it is asked as an MCQ. Pheochromocytoma, parathyroid adenoma and thyroid carcinoma are associated with the glomus tumors. There are 4 common sites of origin of these glomus tumors. One is called the glomus jugulare, where it is seen at the jugular fossa. And second is the glomus tympanicum, where it is, I already told you, this can be seen in association with the tympanic plexus, vessel seen around the tympanic plexus. So that is on the medial wall of middle ear, glomus tympanicum. Tympanicum means within the tympanic cavity or the middle ear. And carotid body tumors at the bifurcation of common carotid artery, bifurcation, and glomus vagal, which are seen on the inferior ganglion, that is at the ganglion nodosum of the vagus nerve, inferior ganglion of the vagus nerve. And these two are usually seen as neck nodes, neck swelling. And we are concerned with the glomus jugulare and glomus tympanicum, which is usually present with the ear complete. Classification. So there are 2 different named classification. One is an Oldring and Fish classification, which was first described in 1979, and this is the upgraded Oldring and Fish in 1982. And also another classification is Glasgow and Jackson, which is more accepted than this Fish classification. Okay, so according to Oldring and Fish, you should know, the postgraduate should know both type of classification, both name classification you should be thorough with. Okay, then only we can, the treatment and also the different approaches depend upon this staging system. Okay, so according to the Fish, type A is it is limited to the middle ear cleft. As I already told you, in the middle ear, in the promontory, there is paraganglia cells related to the small capillaries, adventitia of the capillary, along with the tympanic plexus, or along with the auricular branch of vagus and also the tympanic branch of glossopharyngeal nerve. So type A is limited to the middle ear cleft. Type B, it is going to the tympanomastoid area. I will show with the temporal bone. So the type A is limited to the middle ear cleft. In the temporal bone, it is in the middle ear. Okay, middle ear cleft. Type B is into the tympanomastoid area. So in the, this one is a dissected temporal bone. So you can see the external aortic canal, then the middle ear, and also this one is a cortical mastoidectomy done specimen, temporal bone. So tympanomastoid A is only to the middle ear cleft, and if it is extending into the mastoid area, from the tympanic cavity it is going to the mastoid area, then it becomes type B. And type C is involving the, here there is a petrous apex area. So infralabyrinthine compartment, from there it is going to the infralabyrinthine extending up to the petrous apex, then it is type C. Type C is again divided into C1, C2 and C3 depending upon the involvement of carotid canal. So in this, here is the carotid canal, the outer exit and also the inner exit of the carotid canal. 2 openings, outer and inner. So if it is involving limited involvement of the vertical portion of carotid canal, then it is C1. If it is invading the vertical portion of carotid canal, then it is C2. And if it is invading the horizontal portion of carotid canal also, then it becomes C3. Okay. So type A into the middle ear cleft, and if it is involving the tympanomastoid area also, it is type B. And if it is going infralabyrinthine compartment up to the petrous apex, it is C, type C. C1 is the vertical limited involvement of the vertical portion of carotid canal. If invading the vertical portion, then it is C2, and if invading the horizontal portion also, that is C3. And then if it is going intracranially, if it is less than 2 cm, it is D1. If it is more than 2 cm, it is D2. So that is according to Aldring and Fish classification. And in Glasgow and Jackson classification, it is again divided into 4 stages, both for Glomus tympanicum and Glomus jugulare. And this Glasgow and Jackson classification, it is different for Glomus tympanicum and also for Glomus jugulare. So Glomus tympanicum, I already told you, it is limited to the tympanic cavity. So in stage 1, this is medullary cavity. Anterior relation is the internal carotid artery going anteriorly, and posteriorly we have the mastoid, and also anteriorly there will be the external auditory canal. Okay, and this is internal carotid artery. So in Glomus tympanicum, type 1 is limited to the promontory. Okay, and the medial wall of medullary is a promontory. If it is limited to the promontory, it becomes type 1. And if it is filling the entire medullary cavity, okay, then it becomes type 2. And type 3, what is it? You can guess. It is going into the mastoid area, type 3. And in type 4, what will happen? It is filling the entire medullary cavity, then going to the mastoid area, or it can go laterally into, perforating the tympanic membrane, it can go laterally into the external auditory canal, or it can go anterior to the internal carotid artery. Okay, that is type 4. So very extensive is type 4. So type 1 is limited to the promontory, type 2 filling the medullary, type 3 going to the mastoid area, type 4 is either it is filling the medullary, going to the mastoid, perforating the tympanic membrane and coming to the external auditory canal, or it is going anteriorly to the internal carotid artery. So these are the 4 stages of Glomus tympanicum in Glasgow-Jackson classification. And in case of Glomus jugulare, Glasgow and Jackson again divides that into 4 stages. And as I already told, Glomus jugulare is arising from jugular fossa, and this jugular fossa is related to the floor of medullary. So in stage 1, it is in the jugular fossa. It can extend into the medullary, and from the medullary it can go to the mastoid. So that is 1. So in jugular fossa, then the medullary and mastoid is 1. In stage 2, it is not going upwards into the medullary area, rather it is going along towards the petrous part of temporal bone. That will be better understood if I will show you in a temporal bone. This being the jugular bulb area impression. So here comes the mastoid part of temporal bone. Mastoid part of temporal bone with the impression of sigmoid sinus, then the impression of jugular bulb, and here will be the carotid canal. Okay, carotid canal, and here being the internal acoustic meatus. Okay, so in type 1, it's a very small tumor arising from the jugular bulb area and involving the medullary and the mastoid process. Okay, so type 1, small tumor involving the jugular bulb, the medullary and the mastoid process. In type 2, the tumor is extending. From here, it is not going superiorly, but rather it is going from here, it is going under the internal auditory canal. Here, this is the internal auditory canal. So it is going from here under the internal auditory canal. It is going and may have an intracranial extension, And type 3 is tumor extending into the petrous apex. Here will be the petrous apex. So tumor extending into the petrous apex may have intracranial extension. And type 4 is tumor extending beyond the petrous apex into the clivus. So here will be the clival area or into the infratemporal fossa. Either it is going into from the petrous apex, it is going into the clivus, or here comes the infratemporal fossa area. Okay, so from here can go into the either into the petrous apex area, into the clivus, or into the infratemporal fossa area, and may have an intracranial extension. Okay, so that is the staging of glomus jugulare according to Glasgow and Jackson. And there is also a modified fish classification which divides it little bit complicated, and where A is divided into A1 and A2, B to B1, B2 and B3, C to C1, C2, C3, C4, D again into 1, 2 and I1, 2 and 3, and 5 into 5 extradural and 5 intradural. So those who want to read more can study this also. Okay, so that is regarding the different classifications. And what are the clinical features? These glomus tumors are characteristically slow growing and very rarely metastasis. So from their site of origin, they travel along the tracts of least resistance, especially along the air cell tracts of temporal bone. They can also spread through the vascular lumen or along the neurovascular foraminas, then along the eustachian tube, and also they can spread by direct spread to the bone also can happen. And it also spread into the cochleo-vestibular bone area by ischemic necrosis of the bone. And into the posterior cranial fossa, it can spread into the posterior cranial fossa either through the foraminas or along the cranial nerve pathway, or it can also spread extradurally. Okay, so into the posterior cranial fossa can happen, and also to the through the internal auditory canal. This internal spread through the internal auditory canal is a very good highway for the spread of glomus tumors. Okay, so what all clinical features can happen? See, when it is filling the ear, middle ear, presenting as a pulsatile tinnitus. So pulsatile tinnitus is found, the evidence shows that one of the commonest clinical feature of complaint of the patient will be a pulsatile tinnitus. It can cause hearing loss. Which type of hearing loss? If it is involving the mesotympanum, it can cause a conductive hearing loss, and if it is going into the cochleo-vestibular area, it can cause a sensory neural hearing loss. Okay, so both type of hearing loss can happen. Then oral fullness, it is filling the ear, so there can be an oral fullness, and if it is oral fullness, if it is causing perforation of tympanic membrane and coming to the external auditory canal, what will happen? Bleeding from the ear can happen. Okay, bleeding from the ear. Then pain, otalgia can happen and can cause cranial neuropathy, because jugular foramina there is cranial nerve 9, 10, 11 and 12. So cranial neuropathy can happen. In 35% of cases, cranial neuropathy can happen. And seventh nerve involvement is the last, final, F for F, final, towards the final stages, facial nerve involvement can happen. Otherwise, the earlier, if the cranial neuropathy, first stages will cause hoarseness of voice, dysphagia, later facial nerve involvement, then drooping of the shoulders, etc. Then it can also cause, I already told you, it can be cochleo-vestibular degeneration causing a vertigo. Then if it is going into the intracranial extension causing headache and signs of raised ICT, and in 1 to 3% of cases this will secrete hormones, so that what will happen? There can be the blood pressure will be elevated, heart rate will be elevated, there will be anxiety, panic attack, all these can happen. So these are the main complaints or the symptoms of the patient. That will depend upon the site of involvement and also the stage of disease. Okay. And on examination, first thing we can see is, see this In the initial stages, this will come and this will fill the middle ear, or if it is a Glomus tympanicum, there will be a mass in the promontory or in the mesotympanum. So behind an intact tympanic membrane, you can see a red pulsatile mass, and that we call as a rising sun sign. A rising sun appearance. You have seen in scenery, when we draw scenery, what will we do? We will to hill with the sun. Like that, this is rising from the floor or from the floor of middle ear. So we can call it as a rising sun appearance. And also if we do with the cingulation, we can see the blanching, which is called the pressure. By applying with the cegal speculum, you are applying pressure of the tympanic membrane, so that will cause blanching of the mass inside the middle ear, which is called the brown sign, which it will be positive in case of glomus tumors. So these are the main clinical features. And management, how will you investigate? So diagnosis, diagnostic modality. One is of course the clinical examination, symptoms and also the clinical examination findings that we have already discussed. Second is laboratory, and under that comes radiology as well as examination of serum and urine. Okay. So the most important one is a high resolution CT scan of the temporal bone with bone windows in both axial and coronal plane. Okay. In that you can see the mouth-eaten pattern of the temporal bone, descensus in the floor of tympanic cavity, and also you can see the erosion of the ossicular chain, and that depends upon the extent of the tumor. Okay. And second most important is an MRI scan in both T1 and T2 weighted images. There you can see an heterogeneous opacities, that is both hypo as well as iso intensity will intermingle. And if you are going for a gadolinium enhancement CT scan, which is very much needed investigation in case of glomus tumors, the characteristic salt and pepper enhancement pattern will be seen. So the salt means hyperintensity. Salt is white, no? So it is hyperintense. That is because of the low vascular flow and also due to the intraluminal subacute hemorrhages. And the pepper is because it is hypointense void sign, and this salt and pepper enhancement pattern is showing that there is very intense flow through the blood vessel. Vascularity is shown in this salt and pepper pattern. So this MRI along with a high resolution CT scan of the temporal bone is the diagnostic modality of choice in case of glomus tumors. And you can also do a digital angiogram, especially in carotid arteriography if you are going for as a preoperative investigation, and also if you are planning on embolization. And another one is serum and urine catecholamines, BMA and metanephrine. Okay, so this is to know that whether the tumor is secretory or not, or not, and if it is secretory, preoperatively alpha and beta blockers has to be given. So preoperative use of alpha and beta blockers are needed in case of secretory tumors in order to avoid complication. So these are the investigations done in a case of glomus tumors. And what are the treatment options? The treatment can be, we know the definitive treatment is curative, that is surgery, and there is also a role of palliative therapy with medicines or with basically more of radiation. And virtually all tumors are resectable, but in extremes of age, that is maybe on 75 and above, with a very small tumors, or it is a very gross tumor in a 75-year-old or 80-year-old person with metastasis, there is no point in going for a elaborative surgery. So we can give medicine, basically etoposide and cisplatin is for lung metastasis, and we can also give an octreotide, that is a somatostatin analog if it is somatostatin receptor positive tumor. And radiation can be a curative fractionated radiotherapy of 40 to 50 Gay, or we can also give a stereotactic radiosurgery. That is basically for palliative measures. And the curative or definitive is surgery, and the approach depends upon the extent and the size of the tumor. Okay. And whatever may be the approach, these three should be satisfied. That is exposure of all the tumor margins, similar to that of a juvenile nasopharyngeal angiofibroma. This is also a very vascular tumors. So exposure of all the tumor margins are very important. Identification and control of vital regional anatomy and access to all margins, especially in case of an intracranial extension. So for this we need a multidisciplinary approach, that is more than one approach is needed, a combined approach. And in the coming session we will deal with the different approaches for the Glomus tumor excision.